So first of all, thank you so much for the invitation to be here. One thing that Jerry left out was that I'm also a survivor of metastatic colon cancer, thanks to, well, now this thing is loose. I really screwed this up. Oh, I got it. Fixed it, yeah. So a survivor of metastatic colon cancer, and Jerry's my oncologist. So he left that part out of the CV. The other part is actually not so significant. It just sounds a lot better on paper. I'm going to speak to you about something that actually everybody else has already started to speak to. And every speaker, including Aaron, actually just noted it in a different way. So we are talking at the end of the day of value, and we're talking about access to patient health technology assessment. And I bet, first of all, just around the room, who knows what health technology assessment is? Raise your hand. Okay, and how many people are working in research here? Raise your hand. Okay, all of you have to know about health technology assessment because anything that you're working on that's going to be reimbursed ultimately and approved through our system here in Canada has to go through that process. So it's really important that you start thinking about that early on. And how many people know what patient preferences are? Raise your hand. Well, we were talking about this all this morning, actually. We talked about it in Dr. Filoni's presentation. He talked about how inexpensive the procedure was. So that's health technology assessment, and the open MRI. That's a preference, right? Patients have that preference. Going into a very closed MRI versus an open MRI may change adherence. We heard it in Dr. Fenster's presentation as well. Although I'd like to see that probe, because that rectal probe, I'm not sure, where it would stand in terms of patient preferences, having had those type of ultrasounds before and going back to the days of sigmoidoscopy. Not always, within what I would call the best patient preference, but we also talked about the cost effectiveness of that solution, right? That's health technology assessment. And we heard about cost-effective brain imaging, right? I mean, these are essential things that you have to think about in your research when we talk about, right from the very beginning, when we talk about ultimately having patient access and improved in the healthcare system. So, and don't even get me started on the value-based healthcare, because that's where it actually all comes together, right? When we see that statistic of spending the most amount of all the OECD countries and getting such poor performance in the end result, and that's what we have to change in Canada. So first of all, let me start off by telling you that, like I said, it sounds a lot better on paper. However, the real thanks goes to the team at the University of Calgary, who works closely with me in health technology assessment. Doctors Deborah Marshall, Karen McDonald, and Karina Odejan, who worked tirelessly on this project over years. So I started to say, let's talk about what health technology assessment is. And you'll notice the word value there. So it's a multidisciplinary approach that uses explicit methods to determine the value of health technology at different points in the life cycle of a product or a process or a device or a test or a vaccine or a procedure or a system. We talked about MD clone, synthetic data. Is this cost-effective type of technology that's going to help to change things here? So in the context of Canada, we have many health technology assessment bodies, but the two big ones are what used to be called CADTH, Canada's Drug Agency, and here in Quebec, INES, who look at this every day when they talk about drug approval or device approval in Canada. And it's used to inform decisions about whether or not whatever this we're looking at should be funded in the public healthcare system and reimbursed. And it's not a fun procedure, and we as patients do have input into that. So when we talk about what they look at, I'll come back to that in a later slide. One of the things that they don't always look at is patient preferences. Patient preferences is something a little bit different. And one of the people that started to make me think about it was someone who worked at INES here in Quebec, a health economist. And I was asking him, what weight do you give to the patient experience, the patient data that comes in? He says, well, that's not done in a very research-oriented fashion. And it started getting me think about this many years ago and started to understand the difference between patient preference data and patient experience data. So patient experience data is what you would expect. You know, what's your experience with a drug or your cancer, your disease site, and so forth? Well, that's what we call patient experience data, and we regularly submit that to HTA bodies. But it doesn't provide quantitative information, and it doesn't take into account what we would call trade-offs. I would prefer an oral therapy versus an IV therapy as an example. And it's also very inconsistent depending on the patient or the patient group that's providing this type of information, or sometimes it comes from the manufacturer who conduct these types of studies when they're doing their clinical trials. So incorporating patient preferences is really not that much explored, and we are working on that now with the HTA bodies around the world. This slide shows you a little bit about what the difference is between the two. So on the left, you'll see patient preference information is a qualitative or quantitative assessment of relative desirability or acceptability of alternatives. A thin probe versus a thin probe, a open MRI versus a closed MRI. What the patient wants and what they value is really what we're talking about. So it's qualitative or quantitative data in analytical outputs. So quite the type of thing where I can get the data as a layperson, but I do need the experts to analyze the data. And I'll come back to that because you're going to see a bit about the study that we worked on or are working on. So in patient engagement or involvement, it's a little bit different. This is active, meaningful collaboration between the parties. You may see a clinician and a patient talking together, working together, a researcher across all the stages of the research process. And research decision-making is guided by patients' contributions as partners recognizing their specific expertise in an area, their value and expertise. And you'll start to see the difference in a minute. So where can patient preference data be used? You can see it in the clinical trials and early drug development and identification of relevant endpoints. This is one of the hot topics, believe it or not, in clinical trials. When we talk about endpoints, what's important to patients? On one extreme, you might say the value of hope is an endpoint that's important to patients in a clinical trial. Others may argue it's only overall survival or quality of life, and PFS means nothing, which you'll hear about that too in a minute. The second area that might be of interest is in health technology assessment, or in regulatory approval. So this is where Health Canada would look at something, for example, and look at the benefit risk assessment, or in the health technology assessment lower down. So if you don't know how drugs and devices are approved in the Canadian healthcare system, Health Canada approves it, then it goes through health technology, that's for safety and efficacy. Then the health technology assessment bodies look at it from the point of view, and I'll show you a slide of clinical benefit, economic analysis, that's clinical benefit, cost effectiveness, patient input, and implementation into our systems. And we'll come back to that as well. But when we talk about here, we're looking at alternate patient preferences. That is, we're talking about alternate treatment options that may be available, capturing the non-health benefits. For example, how something is delivered by oral or versus an IV. And the patient preference heterogeneity is very important because we know that it's not a homogeneous population. We have to understand the difference in uptake versus in uptake and adherence, I should say. And I'll give you a personal experience on that. So here is what currently what Canada's Drug Agency on the oncology side, the Pan-Canadian Oncology Drug Review, or PCODR, looks at. They look at, in a deliberative process around the table, they discuss the clinical benefit that's brought in by the industry or perhaps clinicians. They look at the cost effectiveness or the economic evaluation. They look at the adoption feasibility, and we provide input from the patient perspective. Patient groups can do that. And more recently, they're looking at like something that Quebec has been doing for a number of years, but only in certain complex reviews. There's standard review, complex review, and tailored reviews. So in these more complex type of reviews, they're looking at the societal impact. What are those indirect costs that we're talking about that Aaron referred to, for example, being loss of work. What does that mean in terms of our health system? So today, what they do look at mostly is the experience of the patient, or that patient experience data that's reflected in this diagram on the right, where we look at the nature of the illness, living with the illness, needs and expectations of the treatment, and the limitations that they may have, and what they expect to gain from a drug compared to the standard therapy that they're on, that it's being compared with. So I mentioned about this health economist at Ines that got me thinking, and I said, well, we have to do a project on this. We have to really understand how we can give more weight to patient preferences in health technology assessment. So we got together with about 8 groups worldwide with a global grant from Roche initially that I thought I would do in a year, and we're about 9 years into it right now. So that's how research works sometimes. Lots of mistakes at the beginning, and trying to understand what could make a greater impact in the deliberative process by that expert committee that's evaluating drugs and devices to better reflect the patient input and perspective. And we used colorectal cancer, as you could imagine, as a starting point, and that's where we began and where we are right now. So it's a really patient-driven or patient-led research working in combination or in collaboration with academia. So in this study, you could see in the phase 1 of the study, we started to put together our surveys. I lost a year in not understanding what validated assessment tools were, so I learned along the way. And then I worked with the University of Calgary in understanding how to put weights or understanding attributes and the levels that go along with this. And the third part I'll come to, we're not quite home yet, but we looked at different ways of evaluating the patient quality of life versus overall survival benefit in the preference study. The value of the attributes of their treatments, in other words, the benefits and the risks. And thirdly, we looked at the relevant importance of treatment side effects. So as I said, this was for colorectal cancer patients, but we had 3 cohorts. We had the colorectal cancer patients, we had the caregivers, and we had the general population to compare it to. And actually, patients came from across the country because COVID hit. We were fortunate. I didn't have to pay a coordinator here at the Jewish to do that, to work in the waiting rooms. And we used social media, and we recruited patients from across the country, including the general population. And separate surveys were done for each of these cohorts. This gives you an idea of what the survey looked like. So you can see the general screening questions, disease experience, general health-related quality of life. So this is a validated assessment that's commonly used, this tool, EQ5DL. And then we start to get into the background information and the discrete choice experiments, or DCE. So there, in the first one, as I mentioned before, we're comparing quality of life versus quantity of life, or overall survival. In the second preference study, we looked at preferences or attributes in the treatment. Then we got some feedback. Then we did some best-worst scaling, as they call it, looking at some of the questionnaires from the EORTC questionnaires called QLQ30, and went and gave those to the different populations. So let me explain to you, because I didn't understand at the very beginning what discrete choice experiment was. I'll go through 3 studies, and then I'll show you the results of our metastatic population very quickly. So when we talk about comparing quantity of life versus overall survival benefit versus quality of life, we looked at various attributes. So overall survival at different levels from 12 to 24 months. We looked at changes in health-related quality of life. And so the standard where you were at was 70. So anything less than 70 is worse, anything better. You were doing better than 70, you were doing very well. So 50 was the norm. This is how I feel today. And then we asked the question, which treatment options presented would you choose if you only had 2 options, treatment A or treatment B? Treatment A had an overall survival benefit of 16 months and B 12 months. But in treatment A, your health quality was below 50. It went to below 70, which is where you are today, and it was worse. And in the other one, it stays at 70, so constant health. So which treatment would you choose? That's an example of a discrete choice experiment on comparing the different levels of survival over the quality of life In the second example, we looked at the benefits and risks or attributes. These are the attributes. So what treatment would you prefer, an oral therapy or an IV therapy? And it shows here a pill every day for 2 weeks, and then 1 week off. You take it at home. And an IV, you come into the hospital for every 2 weeks, once every 2 weeks for 2 to 4 hours. And you obviously have to come to the hospital. The other attributes, nausea, pain, diarrhea, we looked at, so none or a lot. And finally, PFS, or progression-free survival, ranging from 2 to 10 months. And here the question is, which of the treatment options presented would you choose if there were only 2 options? Treatment A was the oral, treatment B was the IV. But of course, in treatment A, in the oral, we showed nausea, no nausea, but you'd have a lot of pain, a lot of diarrhea, and your PFS would only be 4 months. On the IV side, you would say nausea, there was a lot of nausea, but no pain and no diarrhea, and your PFS would be 8 months. Which would you choose? Or would you choose neither of those two? So we asked those questions. Then in the best worst scaling, we took 25 items from the EORTC questionnaire QLQ30, and we asked them to rate which were the most tolerable or least tolerable of these side effects that you would tolerate. So the most tolerable was the need to rest, and for example, here the least tolerable is depression. So here are the results of the study. Or preliminary results of the study. And I can't take credit for it because I didn't do this analysis, again, back to the team at University of Calgary. But when we looked at the difference, so here you have the patient group, the caregiver group, and the general population. And here it shows your survival, 24 months versus 12 months over here. So out here, you're surviving more. And here you have a better quality of life. It improves to 100 out of 100 out here, worse quality here. And what we found is that patients' overall survival, valued overall survival over the quality of life. Now, that's an interesting thing. The general population thought that quality of life was more important than survival. So we have different perspectives that we sort of found. In this one, in the benefits and risk value of attributes, just to show you here, because it's a bit complicated, but I'm going to break it down in the next slides. Here you have the value of the attributes. Patients, caregivers, and general population. So the light one here is the patients, just to give you an example. Here are the attributes that I mentioned before, oral versus IV, nausea, pain, diarrhea, and PFS. And finally, you could see the sample size in this exercise was 108 patients, 59 caregivers, and a general population of 440 patients. And what happened in the benefit and risk one is we found that the progression-free survival was most important attribute for all 3 groups. Well, that would be shocking to a group called Oncology Outcomes out of Kingston, who argue that the only thing that counts is overall survival benefit and quality of life, and PFS means nothing to them as an to them as clinicians, whereas here you can see how important it is to patients. They valued it very high. So this is really going to, and they're speaking at all the oncology meetings at ASCO and ESMO and so forth. So this is really quite interesting data to show that there is a patient preference for PFS. And you can see it's that same group, 108 patients, 59 caregivers in the population of 446. And likewise, what was more tolerable or least tolerable in terms of nausea, pain, or diarrhea? Well, pain was the most important of the 3 side effects to avoid by all 3 groups. And then finally here, oral versus IV. This is another interesting question because patients actually disliked oral therapy. So on my last treatment, I had metastatic colon cancer, as I mentioned before. And in the last treatment that I had was a drug called capecitabine, which is a huge drug, huge pills, I should say. And my preference was not to have those pills, and actually IV was easier for me. So I discontinued after 1 week the use, even though it was my last and adjuvant treatment, my last treatment. After 1 week, I just couldn't take those pills anymore. So adherence is extremely important when we talk about a preference in oral versus IV. And here you could see that, at least in this study, that patients, preferred the IV versus the oral. And finally, all three groups, meaning the patients, caregivers, and general population, had very similar results when we talked about the tolerable side effects. So, for example, you can see most tolerable for all three groups was a need to rest, and almost the same here in terms of the least tolerable was needs help with eating, dressing, washing, and going to the toilet. So those are some examples how patient preference studies could be used. So you could see here in our trajectory, we've done our national survey in the area with our patients, caregivers, and general population. We've put on the attributes and the weights to it. And now what we're doing with ICER in the US, NICE in the UK, PBAC in Australia, CDA here in Canada Drug Agency here, is working together with them in workshops to see, this is with Health Technology Assessment International, how patient preferences could be incorporated in the deliberative process when they decide whether or not to reimburse a drug. In other words, does this add something more than the patient-reported outcomes or patient experience data? And we think it can because it's done in a research-oriented fashion. But at the end of the day, I would say we're on an uphill battle from what I could see just from these workshops, but it's really important work that's going on, and we do feel ultimately it will prevail. So thanks for the opportunity to be here.